Thank you, Roberto. Thank you, ladies and gentlemen. I'm supposed to give you a very short overview on what interventional radiology is. I don't know how many of us, how many of you really knows about interventional radiology. However, interventional radiology in oncology is usually called interventional oncology, and I will try to give some pictures about that. As you know, and even according to the previous speakers, now you know that the treatment aim in oncology is mainly to achieve chronicity. So it means that, virtually speaking, we do not have any standalone single treatment that may be considered a sort of definitive healing for cancer patients. So, I mean, they are oncology patients for the rest of their life. They will die very old for age, not for disease, but they will stay again oncology patient. In the same way, diabetes is almost the same. So this is the scenario behind the concept to be less invasive as possible. So the silent revolution we witnessed in the last few years is the revolution from the maximum tolerable to the minimum effective treatments. So it is not, as you already seen from the previous speakers, there's no more the time for having very invasive and aggressive surgery, because they are not more justified according to the result you can achieve. So thanks to the better and deeper knowledge of the cancer disease now, today we know that it's much better having a sort of multidisciplinary approach rather than a single treatment strategy. So now the concept of having a treatment strategy is completely replacing the classical concept of single therapy. This is the frame. You can just see what happened in the last centuries. As you know, I mean, surgery has been located deeply within our DNA, because it is the very first form of therapy. I mean, even the Egyptians were treating patients by removing the disease. It was the very first way of treating patients. Then radiation therapy comes up in very early 90s, and since the beginning, I mean, both the two treatments were being combined in order to achieve a better results. And as you can see, along the years, different actors came into the scene, and now we have the chemotherapy alone and the interventional oncology, but just one lines is going up and up. It is the combined therapies that is really focusing our patient management day by day. Okay, according to what you know now, the less invasive medicine is a sort of fashion, and every specialty is exploring new minimally invasive options. And this is true for almost every field. Think about medical oncology with the so-called biologicals. They are very targeted drugs. They are killing specific cell lines. Then we have surgery. They are coming with the laparoscopic, robotics, and many other techniques. They are dealing with the less and less invasive approach. And then we have even radiation therapy with the cyberknife, tomotherapy, and hadron therapy, as you already know from Professor Recchia. But I mean, there's a minimal common issue that may be considered behind every kind of local treatment, that is imaging. I mean, imaging is something that is completely revolutionized the field of medicine, and in the first way, the cancer management. That's the reason why interventional oncology, interventional radiology in oncology is growing very fast, and now it's something that we consider the fourth pillar in the modern clinical oncology, together with the radiation therapy, with medical oncology, and with surgical oncology. And this is mainly due to the very big impact that the imaging gave to the medicine, to the oncology. Think about, we can see from outside what happened inside the body. So we can take advantage of it. It means that we can take advantage of knowing what happened inside the body to guide some minimal invasive instruments to heal the patient from outside in a very precise and less invasive way. So this is what happened in the last century. From the very first image, X-ray image, from today we can have a 4D images. That means we have the fusion imaging tools that may give us some different information coming from inside the body and give us exactly where the very small lesion is located. And we can take advantage of this information for treating the patient, avoiding any very aggressive approach. So we need to change completely the paradigm. Thanks to the new developments in imaging, we can take advantage of it, and we can just approach the patient in an earlier phase of the disease by reducing the invasiveness. Why rational for minimal invasive approach and treatment in oncology? First of all, because we know that when we may reduce the invasiveness of therapies, clinical indication will be wider and wider. Think about not only patients that can be cured, but even patients that should be managed in advanced stage disease. And they, in the past, they were not indicated to be treated because of the invasiveness of the treatment. Then target size, and a very other important issue, because we can take advantage of the size of the tumor. So it means that taking advantage of the possibility to detect the lesion when the lesion is very small, we can reduce the invasiveness, maintaining the level of efficacy. Management of clinical or local regional complex situation. Day by day we may have experience of very difficult situation when the classical approach are not indicated because too invasive. In this situation, minimally invasive approach coming with the imaging-guided techniques may allow physicians and to manage the patient in the best way. They think about the interruption from chemotherapy. I mean, chemotherapy is a sort of backbone in oncology, and sometimes patients need to stop chemotherapy for surgery, and they can restart chemotherapy more than 1 or 2 months after resection, and it is really detrimental for the patient. With minimal invasive approach, we may reduce this interruption, and the patient usually may restart the treatment a few hours, if not, the day after the treatment. And most important, costs, both clinical and economical, are much lower than the traditional approach. Just an organ for let you understood the importance of minimally invasive options coming from the field of interventional oncology. Think about the liver. I mean, we do have many different non-surgical options for healing the liver disease. From the very early disease that can be completely curative to the more advanced stage. So we have radio frequency ablation, chemoembolization, high-intensity focused ultrasound. I will spend some minutes about this topic. Then hepatic intraarterial chemotherapy, radio embolization. And we are not really sure that the main and very old concept coming from the surgical experience that is important to cut the tumor out is really, really necessary. So this is some example that may give you an idea what does it mean to leave the tumor there and kill the tumor within the body. So this is a patient with a single metastasis from colorectal cancer. The patient 9 years ago was ablated, so it means the patient didn't receive the resection. So just one needle that was inserted into the liver according to the guidance of the imaging. And this is a CT scan the day after. You can see how the damaged tissue in the liver is bigger than the original lesion. This is 3 years later, the scar. 9 years later, nothing happens. So the patient completely avoided the resection. So the patient had the ablation the day before she was discharged by the hospital. Thermoablation could be even used for renal cell cancer. This patient avoided to have a nephrectomy for this huge renal cancer. This is the needle. The CT scan was used together with ultrasound for stick the needle to, within the tumor. You can see the needle here. This is 24 hours later. You can see the difference. The tumor was bright because the contrast media was uptaken by the tumor. The day after was completely dark because it was no more perfused. 8 years later, the scar. So the kidney is still there. The only option for this patient was nephrectomy. Same thing for lung. Small, very small metastasis from colorectal cancer. Instead of having lung resection, the patient had the needle from outside. The tumor was ablated. You may see 24 hours later the ablated area and the scar 4 years later, completely healed. So it really works, and this is the reason why it is completely replacing some of the classical surgical approach. And this is what I can say, the cutting-edge technology in minimally invasive approach. By the way, it is the no invasive approach. It is a high-intensity focused ultrasound, so it means that we can cure patient using the sound from outside. Sound is a sort of mechanical energy. In the same time I'm talking to you, you can hear me because my chordal voice are producing vibration. It is a mechanical energy that is hitting your ears. That's the reason why it is the mechanical waves. We may focus those mechanical waves in one dot, and all the energy is concentrated and focused in one point. So this is one example. Actually, the patient is an abdominal surgeon, so he was dealing by resecting many different pancreatic cancer in Milan, and unfortunately he developed pancreatic cancer, and he was referred to me because pain palliation. This is the huge mass that was treated. 2 months later, you can see how the lesion shrunk, and these 3 years later, the patient is still disease-free and still alive. This is a sort of miracle in this kind of big killer tumor. In conclusion, this is some take-home messages. I mean, I was promising to be very short. And so interventional oncology is now replacing more and more traditional surgery. It is happening all over the world. Thanks to the continuous improvement of imaging, early diagnosis of cancer can be done, and we can take advantage of having smaller cancer that may need a less invasive therapy. So we are doing a sort of revolution in the paradigm. So interventional radiology born for being used when surgical resection was not indicated because the tumor was too big. It was just 30 years ago. Now it's completely changed. First step, minimally invasive approach. If we cannot do because the tumor is too big or the patient cannot be treatable with a minimal invasive approach, we can go further with the classical resection with surgery. Again, clinical social costs are much lower where minimally invasive alternatives are adopted. Thank you for your attention.